So, Professor, if you let me introduce you first,
Yes.
my co-workers. If you don't have any trouble, let me introduce you in Spanish. And
Ábrete tu Zoom, que estamos un video así para que vean que estamos. Que alguien habla el Zoom.
sí se escucha en Central Sur, ¿verdad?
Sí, sí se escucha. Nada más tuvimos un problema con la cámara, pero ahí vamos.
Okay. So, Professor, do you want to start at time at 10 o'clock?
Yeah, whatever. I'm okay with your
Thank you.
like your schedule. So you'd want to introduce me in Spanish first, and then you'll just say that please go ahead, and I'll share my presentation and start like after you say, okay?
Sure. Thank you so much, Professor.
Yeah.
Hi, Professor. We are from Mexico City. Quítale el blur. No, es que tiene un blur de privacidad. Quita el blur de privacidad.
No, ahí estamos.
Pero tiene blur de privacidad. Sí, doctor, me encargo. Sí, doctor. Cualidad de los gliomas en Japón. El tratamiento.
So I think we are on time, Professor, so I'm going to introduce you.
Yes, please.
Bueno,
Ahí está.
muchas gracias, Central Sur, por la asistencia. Voy a presentar al doctor Lushun Chalise. Él es de origen nepalí, él estudió en Japón, realizó la carrera de medicina en la Facultad de Medicina en Osaka en 2009 y posteriormente en 2009 hizo la especialidad en neurocirugía. Si pueden apagar su micro, porfa, mientras... Ok. Es certificado por la Junta de Especialistas en Neurocirugía de Japón de 2015 a 2018. Realizó el Fellowship en Neurocirugía Oncológica y obtuvo también el grado PhD en Medicina y Neuro-oncology por la Universidad de Nagoya. En 2018 fue nombrado profesor asistente del Instituto de Ciencias Médicas de la Universidad de Tokio en el área de terapia de innovación en cáncer. En el 2020 se incorporó como neurocirujano en Nagoya Central Hospital y actualmente funge como el jefe del departamento de neurocirugía. Tiene múltiples trabajos acerca de CAR T-cells en el tratamiento de los gliomas de bajo y alto grado y en varias terapias novedosas de cáncer, ¿no? Entonces, thank you, Professor. If you want to start, go ahead, Professor. Thank you. I think your microphone is turned off, Professor. Sorry.
Sorry, can you hear me now?
Yes, thank you so much.
Oh, okay. I'm Lushun. Thank you very much for inviting me for this talk, and especially to Dr. Daniel Vega, and Professor Ulysses Gonzalez, who sent me the invitation. And buenos dias. That's all the Spanish I can say. It's 10 p.m. at night in Japan at the moment, and so, well, I don't want to waste much of your time. Well, we'll just go ahead with the presentation. I'll try to share my presentation now. Can you see my presentation now?
Yes, Professor.
Okay, I'll go ahead with this one then. Okay, so today I'll be talking about gliomas, especially the treatment of malignant gliomas and the state-of-art clinical practice in Japan. So I'll be going through the current Japanese guidelines and our treatment strategies and how we treat gliomas in our hospital and in Japan in general. And I'll be talking like mostly about surgery, but also about other chemotherapies and other emerging therapies for gliomas. And the hospital I work is called Nagoya Central Hospital. It's a teaching hospital of Nagoya University, and I'm a chief consultant neurosurgeon there. I usually do brain tumor surgeries, gliomas, skull base, but also functional neurosurgery and cerebrovascular too. But I've done most of my research in malignant brain tumors. So malignant gliomas, just a basic introduction. I'm sure all of you know about this. But gliomas consist of like 1/3 of all the brain tumors, and high grade or malignant gliomas are what were classically called WHO grade 3 and 4, and glioblastoma is WHO grade 4, and the prevalence is well, like 1 in sorry, it's 100,000, mostly adults, and it has a dismal prognosis. Survival is like less than 2 years, and prognostic factors will include age, performance scale, and surgical resection, and tumor type, grade, molecular diagnosis, MGMT status. And especially these days, the molecular status is more important than anything else. And IDS status is very important for the classification of tumor itself, and MGMT for chemosensitivity. And there are other molecular features that are very important to classify these tumors, especially according to the 2021 WHO classification. And while we still use the classical term of malignant and benign gliomas, the 2021 WHO CNS tumors classification actually classifies these gliomas basically into IDS mutant and IDS wild type. So with IDS mutant, if you have no loss of ATRX and or TPR, there's the TP53 mutation, and if it has a 1p19q 19q codeletion, it is designated as what we classically call this oligodendroglioma. And I have some chat. What should I do? Do not passing the slides. Sorry. Can you see the slides? I'm sorry about this.
The first slide, yes, we'll go the rest now.
Okay, can I continue?
Yes, of course.
Oh, okay. And with IDS mutant, if there's no 1p19q codeletion, the CDK KN2AB wild type, it's astrocytoma IDS mutant. Either grade 2 or 3, and similarly. And with the IDH wild types or MVP, or if there's a third P mutation, EGFR amplification, it's designated as glioblastoma. So these are called adult type diffuse gliomas, and the rest they are pediatric types. But pediatric type gliomas can also be
Ya, sin duda. Se llegó con glasgow de 8.
Let me mute everyone else. I can hear someone else talking at the moment.
Ya es el segundo. Ya es el segundo. Que tiene.
Daniel, can you mute? Okay, I'll mute them. Okay.
Yes, sorry.
Okay, sorry. I'll go on. Okay.
Thank you.
Okay, and that 2021 classification, it grades the tumor within the tumor type. So for astrocytoma, IDS mutant, it could either be 2, 3, or 4 grade 2, 3, or 4. Even oligodendroglioma also 2 or 3, but glioblastoma can only be IDS wild type 4, and diffuse hemispheric glioma is 4. So basically, there's like three. If it's grade 3 or 4, we usually treat them as malignant gliomas. So this is probably a take-home slide that from today's talk. So the guideline for adult glioblastoma treatment in Japan. This is a guideline from Japan Society of Neuro-oncology. The recent one we have is like already 5 years old. It's 2019, but the new guideline will be out anytime soon. I'm not sure if much will be changed, but this is the guideline that we use at the moment. So the first is the surgical therapy. So
sorry, Professor, we only see the first slides, the presentation slides, I think.
Can you see the slides?
Only the first,
okay. Okay, I'll have to redo it again. I don't know what's wrong with this. Can you see the second slide at the moment?
No, the first, only the first.
It's always the first slide?
Yes. Actually, the second is okay. It's on the screen.
I do not understand. So this is, can you see this one now?
Yeah, the second, Professor.
The second and the third.
Yes. Okay, it's okay.
It's okay now. Okay, I'll try to do it once again. So this is the first.
No, on the third.
You're on third.
Yes.
And now?
The third.
It hasn't changed.
No, Professor.
Okay. Okay, I'll just do it with this one then.
This is the third.
Okay. Third. Now?
Fourth.
Okay. Okay, I'll just continue from this one. Okay. So this is the 2021 classification. Much has changed because now you need the IDS profile to actually classify the tumors, and could be the adult type, diffuse gliomas, or pediatric type. I usually operate on adult types, so I'll be mostly talking about the adult types today. I think I'll have to do like this because when I do slideshow, it doesn't work. So is it okay?
Yes, Professor.
Okay, so in 2021 classification, there's grading within the tumor types. So all these tumor types are there first designated as tumor types, and then they are graded like from the scale of 1 to 4. And usually these 3 and 4, these are malignant gliomas. So the guideline for adult glioblastoma treatment in Japan, it's the recent one we have is already 5 years old, 2019, and we'll have a new guideline anytime soon. So this year, it'll be out anytime, but this is the guideline we have at the moment. So I'll be talking about this one. And here there are different recommendations, like grade A is strongly recommended and supported by strong evidence, whereas grade B would be recommended, but there's a moderate evidence. And grade C1 is recommended despite no strong supporting evidence, and C2 and D are not recommended. So surgical therapy is the first line therapy in the gliomas. So the higher the rate of resection, it corresponds to a longer progression-free survival and overall survival for patients in good status. That is recommended at grade C1. And radiation therapy for patients who are aged less than 70 is recommended as grade A. Stereotactic radiation for initial tumors, they are not recommended at all. And for chemotherapy, we all know about temozolomide. The STUP regimen is recommended as grade A. And also there are other chemotherapy agents like nimustine, carmustine, or bevacizumab. They are all recommended as C1. And there's also a PDT, that is photodynamic therapy using talaporphine, natrium, and semiconductor laser. It's also C1. And there's this Novo TTF system following initial chemotherapy as recommended as grade B. So today I'll be talking about these modalities like surgery for newly diagnosed and recurrent cases, and how we balance the extent of tumor resection and neurological symptoms, and chemotherapy, like the standard therapy and bevacizumab. I'll also talk about the carbon-stim waivers and PDT and tumor treating fields, and finally I'll brush through these advances and future directions, which will include oncolytic viruses and convection enhanced delivery and nucleic acid drug, CAR T-cell therapy, and IDS inhibitor. So the Japanese GBM guideline, the significance of surgery is that provided that the patient's general condition is good, a higher rate of resection corresponds to a longer progression-free and overall survival. We all know this. This goes back a long way, like to 20 years ago. There is a trial with biopsy and craniotomy, where early craniotomy had better survival. And again, in 2011, Nader Sanai from UCSF, he wrote this article, and the extent of resection and prognosis in 500 consecutive cases of newly diagnosed glioblastoma that underwent surgical resection and standard therapy. And the prognosis improved with extent of resection of more than 78%, but also there was a relative stepwise improvement in prognosis even at higher extent of resections of 95 to 100%. So the higher the rate of resection, the longer the progression-free and overall survival. And recently, in 2020, there was this article by Molinaro in JAMA Oncology. They actually looked not only at the contrast-enhanced part of the glioblastoma, but also the flare and T2 high-intensity area around the tumor. So they found that for younger patients with IDS wild-type tumors, and while IDS wild types are usually, they have worse prognosis, they have bad prognosis compared to IDH mutants. So for younger patients, IDH wild-type tumors, aggressive resection of contrast-enhanced and also the non-contrast-enhanced tumor had survival similar to that of patients with IDH mutant tumors. So even in these IDH wild types, which have a bad prognosis or poor prognosis, if you resect like more tumor, then the results are similar to that of IDH mutants. And for younger patients, if you do not resect the non-contrast enhanced tumors, then they fared worse. But for older patients, just taking out the contrast enhanced tumor is enough in most of the cases. So this asks to resect more tumor even beyond the contrast enhanced area. So in our setup, what we use is this image guided navigation with DTI tractography and methionine PET spectroscopy and functional MRI, and also tumor visualization with 5-ALA and neuromonitoring. We also do awake craniotomy, not in Nagoya Central Hospital, but we do it in Nagoya University. We're like, there's similar organizations, and we use intraoperative MRI. This is the intraoperative MRI that we have at Nagoya Central Hospital. So these all contribute to glioma surgery. So we believe in aggressive tumor resection, and we have reported a case of a 48-year-old right-handed man with a generalized seizure attack, a long-term survival in glioblastoma. Well, the tumor is very small here, you can see, but even with this small tumor, this is the pathology was IDH wild type. But we did a awake craniotomy, and we were able to resect like the tumor and also the non-contrast enhanced area. So we were able to do a supratotal resection, and the patient is now healthy and functional with no relapse or recurrence at like 9 years. So it's a very long survival for IDH wild type tumor. So this is the Okay, I need to, okay, the animation doesn't work, but well, we have this brain suite that we use, and our MRI is just here, and the patient is lying here. And after we take the MRI, we can, if there's more tumor left, then we can just start operating at the moment. So the patient's head is here. So it's a very convenient system. And what we do is this image guided surgery with neuronavigation based image guidance system. And this pre-operative planning, surgical planning, and then we have this intraoperative MRI, and even like post-operation, we take the MRI just to confirm if we have taken the whole tumor out or not. And the pre-surgical planning would include like MRI, MRS, functional MRI in case of patients who have their functions intact. And MRA, we also use DTI, tractography, and methionine and FDG PETs. We fuse those images and do fiber tracking too, do 3D reconstruction. And this is the planning screen that we have. We have the Brain Lab iPlan. So this is what we use. And in the intraoperative planning, after we take the tumor out, we check for we check the MRI to see if there's any tumor left, or also the MRI imaging of standard sequences like T1, T2. And whenever necessary, we also do DTI for tractography, and then do the 3D reconstruction, and then fuse it with the initial tumor and see if everything is going on all right. So intraoperative navigation with the Kinevon 9000, you could use this augmented reality, with the tumor lying here, and you can see the pyramidal tract here. So this is very helpful even to resect complex shaped tumors like this one. This is a case of glioblastoma with 2 adjacent tumors, and we did a hyperactal approach with this one. But the first MRI showed that a little bit of tumor is left here. So we did the additional resection, and then we were able to take all the contrast enhanced tumor out, and also a little bit of the flare high intensity area too. So this intraoperative MRI imaging is for the confirmation of progress of surgical progress, and real-time confirmation of therapeutic effect of the surgical resection, and update of image information and a correction for the brain shift. Because even with navigation, when the CSF comes out, like there will be brain shift, and for gliomas, it may be tricky. And early detection of any intraoperative complications can also be done with this intraoperative MRI. So this helps with maximum self-resection. So we also operate on tumor gliomas of areas that some people might call inoperable. So resection of gliomas in the vicinity of the motor area. So the objective would be a maximum tumor resection with minimum motor deterioration. So you need to preserve the pyramidal tract and the motor area. So for this, we do pre-surgical planning with non-invasive examinations like functional MRI, DTI, PET. And for the intraoperative evaluation, we use this intraoperative MRI, navigation, and also electrophysiological monitoring. So for intraoperative motor evoked potential monitoring, we do both transcranial and transcortical, but for gliomas in the motor area, transcortical stimulation is probably better. And we first find out the central sulcus with ACP, confirm it by identifying the N20 phase reversal, like this. The primary sensory and primary motor area is here. So the tumor is here. This is a strip electrode we use. And in the subcortical area, in the white matter, we use this bipolar stimulation. We use the same stimulus as the transcortical stimulus. So we just attack the tumor as much as possible and resect it as much as possible, unless we until we get the response with this bipolar stimulator, and then we stop tumor resection when we get the pyramidal tract response. And well, this is an old article from our institution, and it says that the intraoperative tractography demonstrated the location of the corticospinal tract more accurately than preoperative tractography. So when you take an intraoperative MRI, maybe the pyramidal tract has also shifted, so you can actually correct that with intraoperative MRI. So this is our results with 43 out of 217 glioma cases, like almost 20% were in the motor cortex itself. And more than a subtotal resection that we define as more than 95% resection of the tumor was achieved in all the cases. And what you can see that for lateral type tumors, like when the tumor is lateral, and this is like medial type, and this is posterior to the motor area. So, but with the lateral type, there was worsening of motor function in 41% of the tumors cases. But for example, for medial types, you could see that 64% had transient motor deficit, but they improved eventually. So if you do proper monitoring and take the tumor out in such a way, then even if there's transient motor deficit immediately after surgery, they will usually get better. But when you take into consideration that the 30 patients into consideration, these 30 patients with independent preoperative activity of daily life. So, you know, many of the patients who have gliomas in the motor cortex, they already have hemiparesis or, you know, those motor deficits. So it's very difficult to improve them. But if the patient is functionally intact before the surgery, then there's a lot of hope for them. And so even for lateral type, there was transient deterioration in 27% of the cases, but severe deficit was left only in 13%, whereas for medial and posterior type, there was no severe deficit left after surgery. So it's pretty safe. Okay, and then after surgery, we do this standard chemotherapy for malignant gliomas. We already know this, like stool regimen with temozolomide with 75 microgram per square meter of body surface area with concomitant radiation therapy with 2 gray like 30 times. But usually these days we do like 1.8. So we try to reduce the radiation a little bit. And this was this old article from Roger Stoop in New England Journal of Medicine. So this is the basis of today's standard therapy. And this is one of our illustrated cases. This 66-year-old woman with a left frontal lesion. She had no previous medical history, but she came with deterioration in level of consciousness, and she was referred to a hospital for a surgical therapy. And she had aphasia, fine movement disorder, and difficulty to eat and swallow before surgery. And she was operated in our brain suite with neuronavigation, intraoperative MRI, neuromonitoring with transcortical motor evoked potential. And this is the intraoperative MRI image. We're able to take the whole tumor out. And post-operatively, you could see a little bit of a flare, high intensity area left, but all the contrast enhanced tumor has been taken out. And after standard therapy with Stoop protocol, this is the recent MRI with absolutely no recurrence, 42 months after the surgery. She's very healthy. She returned to work. She has her social responsibilities. Actually, she's looking after her husband who has dementia and looking after her son who is mentally challenged. Okay, and then for other chemotherapies, we have bevacizumab. This is sold as Avastin, the trade name, is a monoclonal antibody of VEGF, and it's approved for use in both newly diagnosed and recurrent glioblastoma. It's a grade C1 from Japanese Neuro-oncology Society guideline. And there were 2 double-blind phase 3 randomized control trials, namely Avaglio and RTOG in 2014. And they had a little bit of contradicting results, but the thing is that what we can deduct from that is that bevacizumab has limited benefits. A first line add-on on the treatment to standard therapy in cases where second-line treatment looks unfeasible is a very good strategy to use this bevacizumab, and it may increase progression-free survival, especially in recurrent cases, and it decreases the use of steroids. So while this does not completely cure glioma, it's a very handy therapy to have. And this is an example of efficacy of bevacizumab with a 50-year-old man with a KPS of 90, so he was doing pretty well. He had a hippocampal lesion, and he had undergone 2 previous craniotomies for glioma resection. And during this outpatient clinic follow-up, his symptoms got worse. He developed aphasia, but after using bevacizumab, you can see that the high-intensity area improved, and his symptoms also improved after 2 courses of bevacizumab. And temozolomide was also continued in this case. Okay, so in gliomas, one of the problems is that even if we take the tumor out perfectly and the patient does good after the first initial therapy, there's always a recurrence. So what can we do about recurrent tumors? So sometimes, like in some countries, like for example, in Nepal, where I come from, they usually do not treat recurrent gliomas because they think it's not worth it. Usually, I mean, they treat sometimes, but at least in our institution in Japan, and especially in Nagoya Central Hospital, we try to treat recurrent gliomas as much as possible. So the Japanese guideline for recurrent glioblastoma would say that repeat surgery is recommended, especially in young patients with good performance status, and if the duration is like more than 6 months before recurrence. And if there's total resection, then it's good, but you have to balance the scale with motor deterioration, the neurological symptoms, and tumor resection. And systemic or local chemotherapy is also recommended in the recurrent gliomas. And if there's no other way, then you can also try stereotactic radiation. So this is the result that we have in 39 consecutive cases at Nagoya Central Hospital. This excludes biopsy. So the patients were pretty young, like 50 years old, and they had well, half of them had good performance status, and we're able to do subtotal resection, that is, take out more than 95% of the tumor in 29 out of 39 cases. So 74% of those patients underwent very good resection. And the functional outcome was that one patient actually improved, and there was no change in most of them. In 29, there was transient deterioration in 5 patients, whereas 4 patients, like 10% of those patients, actually deteriorated after surgery. So this is an illustrative case of a 61-year-old male. It's a tumor like this. You can see it's a left frontoinsular temporal tumor. He presented with right hemiparesis and motor dominant aphasia. And this is how we operated. We were able to take the tumor out. We also did this intraoperative tractography. We were able to see that this was intact. So this patient did very good after surgery. And the overall survival of recurrent glioma cases in our hospital is median overall survival is 15 months after recurrence. So I think this is very good compared to all those historical data. And the cumulative survival for 1 year is almost 40%, and 2 years is 25% of the patients that survived more than 2 years. If you divide those patients with good performance scale and not so good, so those who had a KPS of more 70 or more, they did very good. They had a very good survival rate with overall survival of 25 months after surgery. And 76% of those patients survived 12 months, and we had a 61% survival rate for 2-year survival rate. So I think these results are very good if you consider that these patients are recurrent glioblastoma patients. But if the patient has does not have a good performance status at the recurrence, then they do not fare very good. And also, if we compare subtotal resection with partial resection, you could see that with subtotal resection, the survival is very good. It's 19 months overall survival. So the summary is that factors associated with prognosis of recurrent gliomas would be KPS, performance status. If it's more than 70, the patients do good. If you are able to take out most of the tumor, then the patients do good. And if you continue temozolomide, then the patients do good. Okay, now I'll talk about this carmustine wafer, BCNU wafer. It's an interstitial chemotherapy. It was approved for use in Japan in 2013, and it's a C1 recommendation. And diagnosis of malignant glioma, so either grade 3 or 4 is required for this. And maximum you can place like 8 of these wafers in the tumor excision cavity. So, well, in 2003, there was this trial which shows that gliadel, this carmustine wafer, had like some kind of effect on prognosis. So we use it now. But this has like quite limited effect in our personal experience. And it also causes like edema. So this is a paper from Dr. Puramitru. She's from our group in brain tumor surgery at Nagoya University. So after taking the tumor out, in the immediately anterior to the motor area, we put the carmustine wafers, but then there was severe edema after that, and the patient has had transient motor deficits. It eventually got better, but the patient had to go through a very hard time for a few months. Another one that we use in Japan is photodynamic therapy. It's a laser therapy. Unfortunately, we do not have this in our setup, so I'm just going to introduce shortly. So this is like laser feeding talaporphin sodium mediated photodynamic therapy for glioblastoma. And what you do is you give this laser feeding intravenously 24 hours before surgery, and then use this surgical microscope equipped with compact diode laser, and then irradiate the tumor bed. And the results of this trial was out 5 years ago, and showed that patient treated with photodynamic therapy did better, both with PFS and overall survival compared to those of the control. So this does have some kind of efficacy, but the downside is that this is not available in all the institutes, even in Japan. Another one we have now is this tumor treating field, Optune Novo TTF 100A. So this is an antimitotic treatment modality that interferes with glioblastoma cell division and organelle assembly. So it delivers low intensity 200 kilohertz frequency alternating electric fields via 4 transducer arrays on the shaved scalp and connected to portable device. So you have to shave the scalp of the patient, and also you have to use this for at least 18 hours a day. So so this is one of the downsides. A lot of female patients, women, they do not want to shave their scalp, especially in Japan. But this was approved for newly diagnosed glioblastoma in 2018, and currently about 300 patients and cumulative total of about 1,000 cases in Japan, and more than 25,000 cases worldwide have already gone through this treatment. But the downsides are dermatitis and low compliance due to skin troubles and long hours of use, and also financial issues because it is not covered by insurance for recurrent tumors. So if you have to pay out of your pocket, it's very expensive, so not very feasible for Japanese patients. But this is recommended as grade B, so it's one of the highly recommended treatment therapies. Also, this goes back to Roger Stupp's trial in 2017, where temozolomide plus TTF patients did better in both progression-free survival and overall survival. So these are the standard therapies we have, and this is one of the new therapies that I'm going to talk about. So this is oncolytic virus to treat malignant brain tumors. So this is a 3rd generation oncolytic virus, herpes simplex virus 1, and HSP1. It is triple mutated so that it does not damage the normal cells, but only proliferates in cancer cells and also activate acquired immunity. So we did this clinical trial at Tokyo University, where this G47 delta, this virus, oncolytic virus, was given to the patient by stereotactic surgery. We did intratumoral injection of the virus, and after the first injection, we did again after 2 weeks. And then we did the assessment, and then if it was possible, we continued the therapy every 4 weeks for 3 to 6 times. So the results of this trial is out, and it's out in Nature Medicine in 2022, and see that the median overall survival was 20 months, and median progression-free survival was 4.7 months after the initiation of G47 delta. So this is for recurrent or residual tumor. So not from start, but even after the tumor recurs, the patient survived for like 20 months, which is very good compared to historical data. And for both wild type and IDS mutant tumors, they had similar effects. So the primary endpoint was met, and the trial was terminated early because it was highly effective. And then, but there are some adverse events too, like fever in most of the patients because it causes inflammation inside the tumor, and vomiting, nausea, etc. So this is one of the representative cases that we have shown in the paper itself. So this is a tumor before G47 delta treatment, and after the treatment, like before the second treatment, you could see the small, like this black area there, you know. So this is the place where the virus was injected, like in the first round, and this is the 3rd, 4th, and you could see that there's central necrosis here because the tumor began to die eventually, and after 5th, 6th, and after that we observed the tumor. It was stable for 3 months, but after 4 months it again recurred. We did resection of the tumor, but there was again a resection, a recurrence after 9 months. So this is what you do. You make a borehole, and with stereotactic apparatus, we usually with using the Lexel frame. That's what we used. You inject the virus inside the tumor in all different places. And the G47 delta virus, the immune response triggered by virus may also treat lesions that are not directly injected with G47 delta. So there may be some immune response. Like, for example, we treated this anterior part, this part of the tumor, but there was this new lesion very distant from the original tumor. But after treatment with G47 delta to this anterior tumor portion, even this solitary tumor, the isolated lesion, also disappeared. And another advancement that we have is this convection enhanced delivery. There was this phase 1 dose escalation trial using ACNU. And well, while just a phase 1 trial, so it was the adverse events were manageable. There was transient worsening of neurological deficit, but the patient got better. And there was this partial response in 1 out of 6 patients. So this is one of the cases. So this is not this was done in mostly in pediatric patients, but this could be one of the therapies that can also be used for adult gliomas. And recently, this is the newest trial we have in Japan, a novel nucleic acid therapeutics for glioblastoma. So there was this preclinical trial with an animal study done in Nagoya University with combination therapy of anti-TUG1 drug delivery system and temozolomide. It suppressed tumor growth in glioblastoma xenograft mouse model. So you could see this group, which use both anti-TUG1 DDS and temozolomide, they survive much better. So this TUG1 is a taurine upregulated gene one, so it's a long non-coding RNA that inhibits our loop that accumulates in cancer cells and protects cancer cells from DNA damage. So by attacking this TUG1, temozolomide is able to kill more tumor cells by doing more DNA damage. So now a phase 1 investigator-initiated clinical trial using this formula has initiated, and patients have already started to enroll. And finally, this is the chimeric antigen receptor T cells. Well, this has become one of the, or slowly becoming one of the standard therapies in blood cancer. But for solid cancer, especially with glioblastoma, we had only limited triumph. So there were just 2 articles in New England Journal of Medicine. These are good cases that showed response in the clinical trial with IL-13 and also with EGFR variant 3 CAR-T. But you could see that this recent article, this was just out 2 weeks ago. They said that there was good response in 3 patients, but it was transient in 2 of the 3 patients. So this is very promising, but still a long way to go. So one of the problems with CAR T cells is that it's very difficult to target, so-called cold tumors, which are like gliomas. So what we can do is we can use the oncolytic virus, G47 delta, in combination with CAR-T. This is one of the research I did, and we used a combination of CAR-T cell. We made a novel CAR-T cell, LP2 CAR-T, that targeted cancer-specific protoplanin. We also used G47 delta, and we were able to see that the combination effect was much better than the effect of G47 delta and CAR-T alone. Well, it's a very promising result in animal models, but we still have to see it in clinical trials in the future. And this is the final one. We do not have this in Japan at the moment, but this will be ready to use in Japan like very soon. Vorasidenib, it's a IDH inhibitor. So this was this trial and last year in New England Journal of Medicine. So when you use this IDH inhibitor in a double-blind phase 3 trial compared with placebo, for residual or recurrent IDH mutant gliomas, they had better progression-free survival, and also the time to next intervention was significantly improved. So this is a potential therapy for high-grade gliomas, especially IDH mutant gliomas. So, okay, finally, this is how I will summarize our treatment strategies. We do surgical resection followed by standard therapy. We try to resect as much tumor as possible with maximum safe resection. And after the initial chemotherapy radiation, we do maintenance therapy with temozolomide, and we may use bevacizumab or this novel TTF, tumor treating fields, and follow them up in the outpatient clinic for 6 to 2 years. And if there's progression, then they may either be allotted to clinical studies. We have to do molecular diagnosis for that. And there are several clinical trials that are going on in Japan with Japan Clinical Oncology Group. So I haven't mentioned all of them here because of the time restraint, but we either try to enroll them in clinical trials or we try experimental therapies on them. And whenever possible, we try to do repeat surgery. And if nothing works, then you can only do the best supportive care, palliative care for the patients. So this is generally, I guess this is what you do in Mexico and everywhere else, but maybe the clinical studies and some experimental therapies that we do in Japan may be new to you. So the future of glioma surgery would be, in my opinion, so this is like information guided surgery with image guidance and intraoperative pathological molecular diagnosis. We have already developed like intraoperative molecular diagnostic kits in Nagoya University, and hopefully in the future there'll be more robot assistants, and also with fluorescent diagnosis, and of course neurophysiological monitoring is a must. And soon we'll probably go having this image processing technology with virtual reality. So thank you very much. This is my talk for today. I'm sorry for all the technical trouble. I hope you guys understood. And if there are any questions, I'm ready to answer. Thank you.
Thank you so much, Professor, and thank you for your time. I don't know if somebody has a question in South Central Hospital.
Me.
Hi, my name is Alfonso. I'm a third-year resident of Neurosurgery. I have a lot of questions.
Hello, Danny.
Hello, Professor.
I have a lot of questions, but I really want to ask you three principles.
Okay.
For which values of anisotropy factor do you use for the best or the reliable representation of the cortical spinal tract when you are mapping transsurgical? In the IPlan, there is a chart, right, so that you can change and something like that.
Yeah. Okay. Well, well, thank you very much for the question. I do not have the software at the moment, so I'm sorry I cannot answer your question like properly at the moment. But I'll give Daniel my email address, and please write to me, and I'll get back to you. Okay.
Okay. Thank you.
Okay.
A second question:
Okay.
If you achieve a supratotal resection of high-grade glioma or a wild type, is it indicated the therapy with CAR T cells, or or it doesn't work, or?
Okay, we have achieved supratotal resections, both with low-grade and high-grade gliomas. And for CAR T cells, this is only in the experimental phase. In Japan, there's no CAR T cell trial, there's no clinical trial, there's no clinical use of CAR T cells in human patients in Japan, not yet. So we have only done it in mouse models with xenografts using the patient-derived xenografts, but we haven't done it in patients. So it'll be very hypothetical for me to answer your question, but I think when we first start the CAR T cell trial, this is just my personal opinion, we'll probably be starting it only on, firstly, we'll be starting it on recurrent gliomas. So the person, so even it doesn't really matter if we could achieve supratotal resection at first or not. They're probably better to do trials with recurrent gliomas when they recurrent after the first surgery. So, but if you're talking about normal standard therapy, even with supratotal resection, if it's a grade 4 glioblastoma, we do use chemotherapy and radiation, standard therapy.
Okay, and the final, the last one, maybe the most complicated. I know that in our country, we don't have much of these alternatives, much of these techniques. So in your own experience, what do you think is the best choice, the best management that we can apply as a resident or a medical attendant that best brings the best attention for a patient with glioblastoma or a high-grade glioma, knowing that we don't have all these alternatives?
Okay, so that's a very good question. And so it would depend on what are the equipments that you have. So you may not have everything, but you will have something, so the best thing to do is to make to put to the best use all the armor, the techniques that you have, whatever you have, try to do best surgery, best manage patient management with that. So I think the least you can do is try to resect. As neurosurgeon, okay, I'm a neurosurgeon, so I'll talk about it from a neurosurgical point of view. Take as much tumor out as possible, but safely, because there was this article recently that said that if there's a severe neurological deterioration after surgery, it doesn't really matter if it's IDH wild type or mutant. The patient's overall survival will actually be very bad. So the patient will survive less, even if you take the whole tumor out, but the patient had like post-operative hemiparesis, or he was paralyzed or bedridden, because he'll have some other problems. So the first thing to do is do no harm to the patient, but you also have to take glioblastoma, because at the moment surgical resection is the fastest, the best way to deal with those cases. So try to achieve as much resection of the tumor as possible while balancing the neurological symptoms, while you cannot make the patients worse after surgery. So if the patients are healthy and if they are ambulatory, they can walk, they can come to your clinic even after surgery with complete resection, then you can go on with the chemotherapy and radiation. So I guess in most of the centers, in many countries, maybe in the countryside, they're not available, but in the main centers, I'm sure all those standard therapies are available even in Mexico. So you do those standard therapy for the patients. And if the patient recurs, if the tumor recurs, then if you don't have many of those advanced therapeutical choices, the best thing you can do is that if those patients have good performance status, they are young, you know, and if the tumor is resectable, I would recommend resecting the tumor safely. So that will do the patient the most good. And for those who can afford, of course, financial issue is also one of the problems. In Japan, we have this national health insurance, but there's no national health insurance in many countries. I don't know about Mexico, but from where I'm from in Nepal, there's no national health insurance. So the patients have to pay out of their pocket. So you just choose the best therapy that the patient can afford. But as neurosurgeons, what we can do is we can give the best surgery to the patients, and it does not really take much money. You know, I mean, you can do it with the same setup that you already have. I'm not sure if I could answer your question properly, but that's my opinion on it.
Yes, thank you. Thank you very much.
Okay, you're welcome. I think Professor Gonzalez has raised his hand, so if he has any questions.
Doctor Ulises.
Oh, I have a question, Danny, in the meantime. Oh, no. Well,
Okay.
Hello, good morning, everybody. Thank you very much for your wonderful talk. And I have just one question that, yes, can you hear me?
Yes, yes. Go ahead, Professor. Yes, I can hear you.
Can you hear me?
Yeah, I can hear you.
Can you hear me?
Yes,
now?
I can.
Oh, yeah. Okay,
Yes.
thank you very much. I have just one question. What are your findings on the brain when you achieve this supramaximal total resection?
Mm-hmm.
What are the histological findings on the area beyond the contrast-enhanced tumor?
Oh, it's a very, very good question. Thank you. When we achieve supratotal resection, the one thing we should know is that it's not easy to achieve supratotal maximal resection in most of the cases, because real supramaximal resection would be taking out tumor even beyond the flare area. So usually when we define supramaximal resection, we define as the resection of the whole of the contrast enhanced area and also some of the flare high intensity area. So in that case, even in the flare high intensity area, you could find some tumor cells there. So even when we say supratotal resection or supramaximal resection, in radiological point of view, and from oncological point of view or pathological point of view, it's not supratotal resection in most of the cases.
Yeah, my question is because I think that we as neurosurgeons and most of the neuropathologists, they rely more on the oncological findings on that area, and I think we should look for the immunological response of the brain. What is going on in this tissue when it's possible to take it out? And that could be a very good answer about how the brain reacts to the malignant cells.
Yes, yes. Well, I'm not sure if I can answer your question properly, but yes, like in some cases you could see only the gliosis in the ages. So, but I do not really have the answer for like the details of the immunological responses that actually happen at the ages of the tumor, but yeah, I mean, your point of view, I think it's a very interesting point of view.
Hi, Dr. I have another question for you. My name is Rodolfo Molina. I'm a last year resident. In Mexico, we still lack some of the primary care in more rural areas, and thus the primary diagnosis is being delayed. So when the patient arrives here at our third level institution, the tumor is so big, we don't see benefit in offering surgery. Maybe it's because it's infiltrating the corpus callosum or is in all the extent of the left hemisphere. So I wanted to ask you, what's the ratio in your outpatient consult when you see patients with those such big tumors in Japan, and what would be your personal criteria to not offer surgery?
Okay, so we do sometimes get patients with very big tumors, not often. In many cases, they are diagnosed pretty early in Japan, so we tend to get smaller tumors, but sometimes we also get very big tumors. And one of the cases I showed you, the 66-year-old lady, her tumor was really big, but fortunately, it was also in a little bit of a corpus callosum, but only in the genu. So if it's in the frontal part, so it depends on, it's not the size of the tumor, but it depends on the infiltration of the location, and also has it invaded the white matter tracts or not. That's very important. So even if the tumor is very big, if I think that tumor is resectable, if I can resect the tumor and send the patient back home, then I try to do surgery as much as possible. And we have this tractography and all this other stuff. So we do a very good pre-surgical simulation with tractography, and then we discuss and see if that tumor is actually resectable or not. So, and it's very difficult to define eloquent areas, because for like motor responses and for like this classical aphasia, then it's easier to evaluate them. But for example, if you have a patient with a very big tumor in the right hemisphere, then the patient may speak well, he may not have any motor deficit, but he might have problems with his social life afterwards, with working memory problems and all that. It's very difficult to preserve everything, but we try to preserve as much as possible, and we consult the patient, like we tell the patients the possible outcomes, and not just the patient but the family too. So if they're okay with the possible outcomes, then we operate on them. But the short answer is that we try to operate on as many tumors as possible. Even if they are big, we try to resect the tumor volume so that we can take those patients to other therapies afterwards. And generally those patients, they do not do very good if you cannot take the whole tumor out. But since the medical insurance covers almost everything in Japan, the financial issue is not a big question for the patient. So it's just a matter of whether the patient is satisfied or not with the outcome of the surgery.
Thank you, Professor. Si alguien tiene alguna pregunta más.
Thank you so much, Professor. I think if there are no more questions, we can conclude this lecture, and I'm going to send you the certificate letter, Professor.
Okay, thank you very much. It was a pleasure talking to all of you, and thank you very much for your questions. And okay, I'll just write my email address here in this chat. So please send me your questions, and anything I could not answer at the moment, because I don't have all the data with me, I'll send it to you like later on. So this is chaliselushun@gmail.com. This is the email address that I have. So please, Daniel, send it to all your friends who want to contact me, and I'll be happy to answer all of the questions like afterwards, even if I could not answer it right now.
Thank you so much, Professor. You're welcome in Mexico whenever you want to come.
Yeah. I really want to come. I'd like to see you again and see your institution and our friends. Yeah.
Thank you.
Yeah, thank you very much for inviting me. It was a very nice time.
Sayonara, Professor.
Bye. Okay. Bye, guys. Ciao.